Now, after covering airway and cervical spine, we move on to the B in the trauma, that is, how to assess, recognize, and manage breathing problems, especially the life threatening injuries associated with the chest trauma. In this section, we'll be briefly discussing how to assess them, how to recognize them and manage them, and what is pneumothorax and haemothorax. So, breathing in chest injuries. That is, awareness is basically that some injuries requires thoracotomy. Non-surgical management is sometimes indicated, such as passing of a simply chest tube or chest drain. And CT and MRI may be indicated, but that is only and only when the patient is stable. And sometimes severe intrathoracic damage may be so much that massive pneumothorax may ensue and patient may need a surgical thoracotomy. So how to recognize them is to look for the respiratory rate. Then again, the formula stands the same: look, feel, and auscultate. Gasping or labored breathing. Look for plethora and petechiae around the neck and chest area. Cyanosis. Paradoxical respiration, which may be indicating to there's maybe a multiple rib fractures. Unequal chest inflation, which could be due to either hemothorax or pneumothorax. Bruising or contusions, which may be leading to eventually pulmonary contusions. Penetrating chest injuries, which may be eventually leading to hemothorax. Or distending neck veins, which must be recognized because they may be an underlying cause of a cardiac tamponade. Now, how to recognize them? Listen to absence of breath sounds. If the breath sounds are absent, most likely the pathology is on this side. If there's noisy breathing and crepitations, this could be due to laryngeal, pharyngeal trauma, or this could be due to the pulmonary contusions as well. Whether there's stridor veins present or not, and reduced air entry on the unilateral side. If there is reduced air entry or absent air entry, this means the pathology lies on that side. And feel for tracheal deviation. Tracheal deviation indicates tension pneumothorax, so the trachea must be palpated during the trauma. Tenderness, it usually denotes underlying rib fractures. There may be surgical emphysema, which may be due to multiple bronchopleural fistulas or mediastinal injuries or bronchial tree injuries as well. There could be crepitus or instability may be associated with that as well. Now, coming to the management, first we have to recognize what is the underlying problem, then we have to go towards the management of it. Again, in a trauma patient, the problem starts with the A, that is airway and cervical spine. Once we have stabilized the cervical spine, we have controlled the catastrophic limb hemorrhage, then we move to securing the airway, administration oxygen at high flow, ventilate the lungs, and then rule out the life-threatening injuries in the primary survey and convert a tension pneumothorax into a simple pneumothorax. Once we are on the B, we have to make it sure that we have cleared the airway and cervical spine immobilization has been done. The mechanism is such that we see a problem, we recognize it, and we manage it, and then we move on to the next thing. Before managing A, you cannot move to B. It's not that you first look at A, then B, C, and D, and then you start managing it. The formula is as simple that in ATLS you have to first see what is the problem. The first thing is always airway and cervical spine, then comes the breathing. By the time you've reached breathing, you must have managed secured airway and you immobilize the cervical spine. Now coming to the primary survey. Primary survey is actually done to rule out some of the life-threatening injuries such as tension pneumothorax, open pneumothorax, massive pneumothorax, cardiac tamponade, flail chest, and disruption of tracheobronchial tree. Now, what is a tension pneumothorax? It is a buildup of air under pressure in a pleural cavity, leading to compression and collapse of underlying lung. What happens is there could be a kind of direct trauma, or this could be a penetrating trauma, which could result in on the one side of the chest cavity, which can make resulting in a tension pneumothorax. Once the air builds up, is actually the lung has collapsed and the air is building up on the one side and actually creating a lot of pressure, which pushes the trachea away towards the other side. This leads to ventilation perfusion mismatch and eventually leads to hypoxia, shifts the mediastinum and trachea to the other side, And as the mediastinum is going to shift towards the other side, this also results in loss of cardiac output. That is, it is resulting in a hypotension and pulseless electrical activity or cardiac arrest can occur. But usually this is at a very advanced stage if it's not corrected quickly. What are the signs and symptoms of tension pneumothorax? Usually this is a clinical diagnosis, and radiological investigation is usually not required until unless you secure the airway and you have cleared the patient of tension pneumothorax, then only you order a chest x-ray. Usually not radiological. How to make a diagnosis? The cardinal signs symptoms include absent breath sounds on the side of the pneumothorax, deviated trachea towards the opposite or away from the tension pneumothorax, and hyper-resonant percussion note, which means there is a lot of buildup of air, therefore the percussion note would be hyper-resonant on the side of the pneumothorax. For example, if the patient has developed a right-sided tension pneumothorax, there would be absent breath sound on the right side of the chest on auscultation, there will be hyper-resonant note on the right side, and trachea would be deviated towards the left side. This denotes that most likely this patient has a right-sided tension pneumothorax. Immediate management, because it's a surgical emergency, it's a life-threatening emergency, it has to be managed before. We do not need to order chest x-ray. We have to clinically diagnose it and do the management. Once we have done the management, then only we can think of a chest x-ray. Immediate management includes decompression by a needle, thoracentesis. If you see it over here, this is a dummy and the needle is being passed. This is simple cannula or 14 gauge cannula which can be passed in the second intercostal space. That is just to give this air enough room so that it can escape some amount from this cannula, because this is a build-up of air pressure under pressure, so that it will escape through this cannula. This will actually relieve some of the pressure which is actually built up inside before we can go for the definitive management. As I told you, insertion of 14 gauge cannula into the pleural cavity. It's simply going to be an IV 14 gauge cannula, and then to go for open thoracostomy, which is usually not performed, then we can go for drainage. What has happened is that once we have passed this cannula, it gives us enough time that we can arrange the system for chest tube intubation or you passing of a chest drain, which is important because for lung reinflation, there's no technique. It's not performed bilaterally. This is important because if the problem is on one side, we cannot pass it on the other side. We have to first recognize where's the site, and then we get passing of the chest drain in the fifth intercostal space, which is the passing of chest tube is the definitive management for tension pneumothorax. Now coming to the open pneumothorax, this is called a sucking chest wound. For example, if this patient is having a problem where the multiple rib fractures and there's an open wound which is therein, the pressure inside the lungs is far low and outside the air pressure is high. So actually the air moves in and cannot come out because there is a lung collapse, and when the patient is actually inhaling and exhaling, only this lung is working. This lung is not expanding to generate enough pressure to move the air out. So this is resulting in only a kind of a one-way valve that the air is only moving in to create a tension pneumothorax. Therefore, in open pneumothorax, we have to be a little different in approach. What we do is we close this huge gap which is actually present in the skin and actually causing this kind of a pressure difference, and that to make it into a simple pneumothorax. And that is how we can do is we call it a three-way dressing. Basically, as I told you, air is drawn into the pleural cavity, causes paradoxical respiration, and lung deflates on aspiration, causing hypoventilation and hypoxia. Specific immediate management includes this occlusive dressing called as three-way dressing, that if this is the area, you simply put a gauze pieces in and you will block it from three sides, that air can only enter through this. So what happens is this actually converts an open chest wound, open pneumothorax into a simple pneumothorax. As a result, this acts as a one-way valve and air cannot move in, but once it's some degree of expansion does occur, the air can come out. So therefore that actually reduces the continuous buildup of pressure. And once this has been converted into simple pneumothorax, we can pass the chest tube to relieve the patient of its symptoms. Now coming to the massive hemothorax. Hemothorax is actually a collection of blood in the pleural cavity. We call it a massive if there are three indications. That is, the patient has some kind of a bleeding in the thoracic cavity. We have passed the chest tube, and on passing of the chest tube, there is more than 1500 ml of blood which has come in the chest drain in the stat. That is, as we have passed it, there is actually massive gush of blood into the chest drain. Or if there is more than 200 ml of blood which is coming into the chest drain for more than 3 hours, 3 to 4 hours, that is an indication there is continuous bleed inside. There may be a large arteriothoracic vessel which may be injured, and this large vessels may be leading to massive hemothorax. So it is, as I told you, accumulation of blood in the thoracic cavity follows blunt and penetrating chest tubes. This could lead to hypoxia and shock, which is usually the hemorrhagic shock, or smaller hematosis can also, that is degree of collection of blood in the thoracic cavity, can also occur. May be associated with fractured rib and your minor venous injuries, but usually there is a major thoracic vessel which may leads to massive hemothorax. Diagnosis and management. Diagnosis is presence of hypoxia, reduced chest expansion, absent breath sounds, dullness on chest percussion. In tension pneumothorax, there was hyperresonant note. In hemothorax, it will be dull note or dull percussion note, and associated with hypovolemic shock or hemorrhagic shock. Supine chest percussion, there is actually no dullness. Why? Because once the patient is sitting up, this goes down. This whole blood accumulates over there and there is no dullness. But when the patient is upright, there is air over here, there is no dullness in this area, but where there is accumulation of blood, this leads to dullness of the percussion note. Management. The first is the chest drain, which is important. Or if the patient, there is a massive hemothorax, we may need an open thoracotomy. And correction of hypovolemia, tranexamic acid and blood transfusion has to be given because there may be a massive bleed inside. Or surgical rafter thoracotomy, which may be indicated, which is very important. That we first is passing of chest tube. Once the chest drain is passed, we have to look for how much blood is coming out. If we are suspecting there is continuous bleed, then we have to go for open thoracotomy. In this section, we have briefly gone through some of the problems which may be associated with the breathing difficulty in the patients, and we have to rule out the life-threatening injuries such as tension pneumothorax, simple pneumothorax, massive hemothorax, cardiac tamponade, flail chest. We have briefly discussed the management of the tension pneumothorax and massive hemothorax. The mechanism of management of the tension pneumothorax is to convert tension pneumothorax to a simple pneumothorax and then pass a chest tube. If we have passed the treatment for the hemothorax is actually passing a chest tube, but if it turns out to be massive, then it may require an open thoracotomy. Thank you very much. Keep watching sqadia.com.